Hello and welcome to Sensei podcast. This is Manos Brilakis discussing with leaders in the field of CTO and complex PCI. Sensei means teacher or master in Japanese. The goal of the Sensei podcast is to help you learn and improve in CTO and complex PCI so that you can become the best that you can be and offer your patients the best possible results. Hello everyone and welcome to Sensei podcast. It is my great pleasure to introduce our guest today, Dr. Juan Russo from Foothills Hospital in the University of Calgary in Canada. Juan, thank you again so much for joining us today. It's a great pleasure to have you on the podcast.
Thank you for having me, Manos.
And Juan, you have done a tremendous work on CHIP. You have done a work on out-of-hospital cardiac arrest, many different things. But maybe go from the beginning. How did you go into medicine? How did you decide to do interventional cardiology?
If I reflect as to how I went into medicine, I can't really recall exactly what factors came into the decision. I was debating between engineering and medicine. And sometimes I wonder if engineering was the right path for me, for example. But once I was in medicine, I kind of missed the concept-based learning of engineering, that system of thought. And I think that's what made me I'm more inclined to critical care and cardiology. I found that some of the same concepts applied rather than memorizing algorithms. Sometimes concept-based learning was rewarded. And then in internal medicine, I debated between critical care and cardiology. Ultimately, I was interested in critical care medicine, but I found that cardiology gave me more breadth to be able to care for patients, not only in the intense setting, but also under an environment that was more chill. I did quite a bit of critical care rotations. And once I rotated through trauma, I realized that maybe some facets of critical care were not necessarily for me. And then in cardiology, I found myself gravitating again towards the sickest patients who were in the CICU. And I found that interventional cardiology was, I would say that the additional training that was more transferable to that area. Resuscitating patients, because coronary artery disease is still the most prevalent condition in CICUs. And then once in interventional cardiology, I had become kind of infatuated with MCS for different reasons. I still do find that ECMO, even in the context of ECPR, is beneficial for a specific subset of patients, and I wanted to pursue that further. And that's ultimately how I ended up wanting to do fellowships abroad. Ended up working with Dimmitri, Jeff Moses at Columbia, and was exposed to the CTO chip realm while looking for both, complex PCI for the sickest patient, as well as some exposure to MCS. Yeah.
And you have actually have this unique blend of the complex coronary work and CTO and CHIP, but also covering the critical care, which many of us have lost touch completely, and we don't do any rotations in critical care, and it's two different mindsets in a way. Do you find that having expertise in both helps each other? How do you see the relationship between those?
I mean, there's a growing movement towards subspecialization in critical care. And a lot of this subspecialization is geared towards training people in critical care fellowship. If I were to ask myself the question, if I needed somebody to cover the CICU of the future, what skills would I want them to have, right? So there are some skills in critical care, like managing the vents or assessing difficult airways, bronchoscopy, let's say, that may become more prevalent. And then other skills like trauma or even very difficult to vent patients that seldom come into play in the modern CICU. I have a feeling that cardiogenic shock is still the thing that makes people the sickest when it's intractable. And that requires swans, which have fallen out of favor in the medical critical care setting. And there's also cardiac arrest, which I find is an area where we have made very little progress. And there are a number of nuances when it comes to neural prognostication that do definitely apply. A lot of the things that, even though remain unproven, may become injurious to other hospital cardiac arrest patients if not addressed in a timely manner. So I would say in the current era, by textbook, like I never fully pursued critical care training. I was actually advised not to by my mentors because once you finish CHIP CTO, it's very difficult to leave that for 2 years to focus on critical care and then come back. The whole field may have changed. Um, uh, so in that context, I would say that I wouldn't consider myself in the current era like at the forefront of critical care. But I do find that as an interventional cardiologist interested in CHIP, interested in out of hospital cardiac arrest, I find myself having a lot to contribute to that area. Yeah. It's kind of an interesting question because I think there's diverging opinions as to what the optimal training is for critical care cardiologists in the current era.
Absolutely. And there's also the group that does advanced heart failure as well as intervention. So there's different pathways, I guess, to deal with the same very sick group of patients. But coming back to
I
the
think the secret is like remaining a good internist, like never forgetting internal medicine. And that requires volume and kind of staying on the field, right? I think a good interventional cardiologist with an interest in internal medicine that never ceases to exist is a good critical care cardiologist.
yeah, absolutely. And that's again a skill that unfortunately many interventionalists have lost these days. But coming back to the chip, so you were interested in complex, and you were in New York, with Dimitri and Jeff Moses and a great group of operators. What made you want to do complex versus to the regular PCI and then focus also on the critical care?
Yeah, I would say when I went to New York, I was as excited about CTO chip PCI as I was about MCS. And there's a number of things that I realized when I arrived in New York. The center where I trained in Ottawa, it was a very high volume center. So they did quite a bit of procedures. And I had this notion that I was well prepared for what I was gonna see in New York, just based on the volume that I've been exposed to. But I kind of quickly realized that it was a very different experience. I find that in high volume, there's a lot of doing, and there's often a space that we encounter kind of in chip CTO where the advancement of the procedure is much slower. There's a lot of thinking, and that requires a specific set of cognitive skills, like knowing where you are in the architecture of the coronary artery. Those were the sets of skills that I found quite surprising. So when I arrived in New York, I was in a bit of a state of shock, like knowing where is this wire? Like, is it subintimal, true lumen, etc. It's a very steep learning curve. And I found very quickly that the operators, the CTO chip operators, have a greater ability to know where they are in the architecture of the artery. And as a result, they can take calculated risks, which often do pay off. I saw Dimitri get out of situations that I found were not, physically possible, simply because he knew where in the artery he was located. And I found that process sometimes it's is time consuming, It can even be frustrating when you're the primary operator. But there's a lot of learning in that realm, and that learning is definitely transferable to Type A PCI. I do find that when you struggle with these lesions, you're often able to get out of situations that maybe you wouldn't have been able to get out otherwise. Like you learn to live and thrive in the subintimal space. So when you have a dissection and when PCIing a Type A lesion, you feel better equipped to address it.
Perfect. And that's again one of the things that it helps. But of course, to be able to use these techniques in the acute setting means that you've practiced them and you're very comfortable, as you say, dealing with them. What did you find the most difficult thing to learn in the CTO chip area?
Um, it depends. I would say in the chip CTO era, I would say in fellowship, let's say, there's a point in fellowship where you feel like you're ready to take the next step. And now, um, as a staff doing ship CTO procedures and having fellows with me, I realize what it feels like to be in the other role when you're trying to balance allowing the fellow to have a learning opportunity and also safeguarding the procedure. Because in ship CTO, a very small mistake can prolong a procedure indefinitely. Um, I found that I was a very, let's go, let's do this, like a very action oriented. And throughout the fellowship, I learned that it was very important to step back and to not just learn about the technique, but also learn about the indication, the pre-procedural planning. That was a part that never really occurred to me. When you come to PCI, there's STEMIs. STEMI lesions are easier to cross. You don't necessarily develop a plan A, B, and C proactively. You just assume that plan A is going to go well because it often does. I think that discipline to slow down and to do things even when initially you think you have a plan in your mind was a very good learning lesson. And it'll definitely pay off. Like if you don't spend like time looking at the angiogram and your plan A fails, and then you're wondering what other collaterals you can use, is often better to have those collaterals in your memory rather than to start looking for them when maybe they can no longer be visualized. So that discipline, I think, I mean, it seems kind of to say that you to become more disciplined is a learning exercise seems weird, but it was like to understand that you need to know the case inside out before you step in.
Yeah, absolutely. And how do you deal when things, as you said, don't go well, as the plan A doesn't work? So either a complication happens or the procedure fails to advance. How do you deal with this?
um I do find that um there's I'm not sure if this happens to other operators, but there's a situation in which if things are not going the right way and you're struggling, you become hyper focused, and you kind of get a sense of where you are and what you need to do. That would be one of the challenges that I would mention in Manos learning in chip CTO is communicating with other team members and working as a team. So in these situations, making sure that everyone is on board with what's going on, everyone is up to date with what the next steps are. But I would say that at that point in time, I become very, very focused on what it is that I need to do. That I would say that in general, when things are not going wrong and you are struggling, that phase for me is almost like, I mean, sometimes things don't go as you wish and then you have a plan B that is a clear plan B. But I'm saying when plan A, B, and C have not worked, and then now you're deciding between different options, none of which have guaranteed success. I would say that realm is very uncomfortable. But at the same time, it is a place of great learning. So sometimes the way that I help myself through that state is just over time recognize that those are the situations in which, when you kind of adapt the algorithm to the specific patient, you learn at a really fast pace. Um, yeah, so I would say those are. I hate being in that place, but at the same time I understand the value of that place. Yeah.
And again, when things when there's a complication, do you get depressed? Do you get frustrated? How do you deal with the complications?
Yeah, I would say personally, in the same way, I'm not sure that I am the right person to give advice as to how to deal with complications, because I take it in. And obviously depends on the nature of the complication, right? Like if it's a complicated, let's say if it's a perforation where you put in a pericardial drain and the patient will be okay. That's a different complication than, let's say, if you have a stroke as a complication from PCI.
Yeah.
So when there's kind of an irreversible uh, um, complication that will impact the patient's life, I think I take it with me, and I would say similar to that place that I was watching I don't know if you watched the movie Whiplash.
Okay, I haven't seen it, but
No, it's a this guy playing jazz drums in a very prestigious school, and the learning environment is so tough that if you survive, it guarantees success, but it takes you very close to the breaking point. Let's say. I would say with complications, I sit on them. Like sometimes I'll dream like of all the permutations that could have happened, or I find myself waking up in the morning and the first thought is like, well, what if the wire had moved this way? I'm not sure that's healthy. It's definitely a good learning, like to ruminate on something. There's learning in that, right? Because if you spend time thinking about it incessantly, you will learn, but it just doesn't feel comfortable. And I would say I just have to wait for it to pass. Yeah. It seems like I have no, yeah, I don't know. I would say it's the part about chip CTO PCI that I dislike the most. Just that time after these events, because they're more common in chip CTO PCI. And I find you live through them. Yeah.
and then which is do you remember which is your best case ever? Is there a case that you um, think the most remember the most fondly out of all the cases you've done?
Uh, to be honest, I cannot. Um, I cannot recall a case for some reason. Manos I think that's part of the psychology of medicine. Let's say that you seem to only recall your worst cases, right? And then your best cases,
Yeah.
you're like, okay, we did what we were supposed to do. I can't really think of I have had cases where I felt like usually in chip CTO PCI, um, like it just out of if I were to go with my gut, like my my gut memory, it probably wouldn't be a chip CTO PCI, because a lot of the times they are elective procedures. The patient's stable. I would say my best case would not necessarily be only a technical case, but it would be a cognitive case where you took a patient to the lab under the right circumstances, maybe in a non-STEMI, and did something that ultimately improve the patient's outcome. I think that is more likely to happen in regular PCI than in chip CTO PCI, because I think success is not just about the technique, but generally the overall outcome, right? And chip CTO or CTO PCI, and even chip PCI, because you have to consider the indication is usually done in a more controlled setting. Yeah.
Perfect. And then when it comes to teaching, you've been teaching fellows. Um, what excites you when you have someone coming to learn from you? What makes you excited to want to teach that person?
Um, I think when I get a fellow that is really passionate about, or we have passions in common, let's say, like if they're truly interested in chip CTO PCI, or they're interested in cardiac arrest, I find that just the love or the passion for something can change the path of somebody else's life. um like I think we can teach people how to do procedures and techniques, but sometimes we can influence others by showing them like what there is to like about chip CTO PCI. Just like, sometimes people can teach you about their own, like music. Sometimes people can teach you the beauty of music in a way that you've never seen. I think that is something that excites me when I feel like I have the opportunity to instill a sense of wonder about chip CTOPC. And that depends obviously on the person's interest, right? Like you can't force somebody to like, chip CTOPCI as opposed to a structural. But when they do, it's a good thing to have somebody who is actually willing and interested in learning the skills.
Wonderful. And then when it comes to the out of hospital cardiac arrest, what made you get excited and want to work on this area? I know that you've been working on this for a while. What was the initial impetus and what keeps you excited about it?
Yeah, like I uh so I started in Ottawa in 2014. Michel Lemay is an interventional cardiologist in Ottawa. He did the Safari trial, and he has the Capital Chill trial, and he was really interested in out of hospital cardiac arrest. He has the large registry. um, there was an instance, a story that kind of went around the CCU of a patient with an out of hospital cardiac arrest whose baseline characteristics, the low or no flow time, is were just indicative of a poor outcome. And the patient was in the CCU, and it had been days that they were doing neuroprognostication, and all the physical exam findings and some of the imaging findings suggested a poor outcome. And as a result, the patient family was advised of kind of the poor prognosticating factors. Family meeting was held, and during the family meeting, the family said, I can feel that the patient, that our loved one is communicating with us. And the team is like, it's always very hard to be in the situation. Sometimes people can make movements that are not purposeful, etc. I'm kind of confabulating because I wasn't there, but ultimately the ending of the story was that the family asked for an extra day, and for reasons that remain unexplained, that day was the day the patient woke up. um, I'm not trying to say that there's miraculous situations that should make us want to wait indefinitely. I just feel like in cardiac arrest there are still hidden variables. I've seen patients be transferred to the cath lab with an anterior STEMI, and out of hospital cardiac arrest that has an incredibly long low or no actually usually it's an incredibly long low flow time. Have paramedics tell me, I'm not sure why we brought this patient here. They've been doing compressions for 60 hours. And we're like, well, the patient's here, so we might as well do whatever we can to as opposed to, because it's difficult to stop to be the person that basically, based on perhaps partly your own values, stops the care of the patient. And I've seen those patients. I can tell you at least like 5 or 10 that ultimately have an amazing neurologic outcome. And I talk about amazing as in basically cognitively intact, not amazing as in trauma critical care where somebody like unfortunately has some sort of head injury, and even though they survive, they're left with significant deficits. So I know that there's obviously like a simpler explanation that a lot of the times the way we measure the variables, the low flow time are inaccurate, right? Like, if somebody has a cardiac arrest without a pulse for 60 minutes, maybe that is verifiably bad when it comes to long-term outcomes. However, did the patient actually not have a pulse? Was the cardiac arrest fragmented? I remember, like, to tell you as a kind of half a joke. When I was in internal medicine, I had PA arrest. I think it was on my first like 2 months in residency. So I was there, and it was like the first time that I had a patient die on a code. So there was the senior medical resident. I was kind of doing chest compressions, etc. And I remember I was trying to talk to somebody about it, and then that resident told me, like I've never had anyone die uh, during a PA arrest. Like I've always managed to get ROSC, right? And at that time, like that comment, I remember it stayed with me, and I'm like, what could we've done different? This is, by the way, a patient like aortic stenosis on dialysis, that sort of thing. Like not an easy person to resuscitate. But then it occurred to me, like, I wonder, like, how many times we do chest compressions without properly feeling a pulse? Because, like, PA arrest, like, the survival is not 100%. And a lot of the times people are just severely hypotensive as opposed to, uh, pulseless. So I wonder how this applies in out of hospital cardiac arrest. And, the example that I gave you is a typical example of the self fulfilling prophecy where if a lot of these patients will die and nothing will seem wrong because there's nobody that can prove that they would have survived otherwise. So that part interests me. But I would say mostly the hidden variable. Like, what is that variable? How much of the cards are played, before we get ROSC, and how much of the immediate post ROSC environment affects outcomes? That part I find really interesting. And obviously, the mortality is bad, so a lot of space for improvement.
All right. So Juan, you do again a lot of work in many different areas, so very, very busy. How do you keep yourself in good shape and a good mood?
Um, yeah. So I have a dog that is always happy, and happiness is contagious. Um, I more recently, actually, because as part of fellowship and residency, uh, you kind of live in a rat race where your entire life seems as expected to be medicine. Like you can have no interest or desires outside of the hospital. I think that is also true when you, or at least for me, when you first become staff, you feel like you've had this job and you owe it to people to have no other priority than to cover whatever needs to be covered. And then, there's a transition period where you start feeling more comfortable with yourself, and understanding that, that there are beautiful things outside the hospital. In fact, most beauty in life lies outside the hospital, right? There's a lot of sadness inside hospitals. So I would say I exercise. I love biking. So biking to work makes me happy. Even biking when I'm not at work, but when it's really busy, biking to work, I think is excellent. I listened to a podcast recently that talked about land snorkeling. I'm not sure. I never heard that term, but it's basically like looking at the details when you're above water, kind of like you do when you're snorkeling. Like that sort of thing happens when you bike to work. A lot of times, if you drive to work, you're in a capsule, so you can't really see what's going on around you. You know, the smells, like the bakeries are opening up, etc. So I find that's very useful. And I try to look for things that create a sense of wonder, like I think CTO and medicine is, I find it fascinating, but at the same time, it's very prescriptive. Like there's a limited space for creativity. I try to find other realms that allow for creativity without the risk. You know, like you don't want a really creative interventional cardiologist necessarily. Yeah.
And then, how many hours do you sleep?
It depends. I got this. I'm not sure if I'm allowed. I got this like fitness tracker that reminds me. I used to sleep maybe 5 or 6 hours per day because I found that I was most productive at night. More recently, I realized that the reason why I felt perpetually tired was because I didn't sleep enough. So I'm trying to be better on that. So I would say that I'm now averaging about 7 hours. Um, yeah, it requires. I mean, that discipline that you develop over time, I think, makes you more efficient, and that allows for more sleep. But some of the times, let's say if you're in the cath lab and it's a long day, and you feel like you have to do something for yourself, um, you come home and you force yourself to stay awake, to feel like you spend time doing something that you enjoy. I feel like most of those times that activity should be sleep. Because if you're that tired, a lot of the things that create wonder or kind of make you happy are not things that you have the mental energy to do. You end up spending time in like watching bad television, and that is not worthwhile.
And speaking of that, do you have any favorite movie and any favorite book?
Um, I love movies, so I have a lot of favorite movies. Trying to think. I mean, in recent times, I really liked Poor Things. I liked Triangle of Sadness. Kind of older. Actually, it's not even that old. I love There Will Be Blood. I find that that is a masterpiece. Um, and then books. I recently read a book called The Courage to Be Disliked. I went on Google and looked at mind blowing books and came across this book that reads kind of like a self help book, but it deals with that Lyrian psychology, and I found it fascinating. On that same search, I came across *Sapiens*, which I found was a really, really good book. And then just recently, I am half reading, half audiobooking *The Order of Time*, which I find yeah, very, very interesting.
So keeping again yourself very, very broad, very diverse, and finding enjoyment outside medicine. So, what if you had to say what are the things that you are most proud of, medicine or outside medicine? What would you say?
Um, I would say that Uh, I I spent a lot of time focused on medicine, like as a resident fellow. Uh, I can't really say like when I think of something that I'm proud of outside of medicine, like nothing naturally, let's say, comes to mind. Um, Within medicine, I would say that it would be just the perseverance. I feel like my way of thinking, like my vision, didn't necessarily or wasn't the average, let's say. So sometimes when it came to medicine, there were times where I had to learn in a way that was not the natural way for me to learn. You know, like for example, memorization. I found really boring, right? That I just have to memorize like facts, and that required perseverance. And I'm proud that I stuck through that. I don't know what the path was for other people, but I feel like I made a significant amount of sacrifices to be here, and I'm proud of that.
And also, in addition to the clinical work, you've published extensively on high complex PCI and multiple other areas. How did you cultivate that skill? Was it part of New York? Was it part of Ottawa? How did you learn to do the studies and write up?
Um, Yeah, so I really do enjoy the process of research, and I found that in medicine, that there are ways in which you can be creative or think creatively in medicine, but sometimes they're limited in day to day clinical care. I found that research allowed kind of a new form of constricted creativity. And it dealt with, like if you feel like your life revolves around medicine, and you want to be creative, sometimes you can channel that creativity to research. I do find now, as later in that process, that there's also quite a bit of constriction in research. Obviously, the gold standard is a randomized control trial, although I do find that with personalized medicine and AI, the possibilities are fascinating. But I would say that the other parts of research, the funding, the competition, are ways in which you have to almost change what you want to do in a way that meets kind of the expectation or the desires of the system. So I'm trying to find a way to work within that. So right now, for example, I have a database that I'm exploring related to out of hospital cardiac arrest. And I it doesn't require money, and I do it in a way that I think is scientifically sound, but it requires me to be independent, or allows me to be independent in the ideas, if that makes sense. And I do find that AI, I'm starting to now that you can code through AI. I found that productivity has gone up. So for a lot of this research projects, I would get people who were really good at coding to code. So that I could put data in a way that I could analyze. And now I find that I can do it myself because I can find ChatGPT to develop a code for me. And I find that really fascinating. So I feel like it lowers the or levels the playing field a little bit.
Wonderful. So, if you had to say the most exciting thing right now, both clinically, research, or otherwise, what is the thing that you're most excited at this time going forward?
Uh, uh, Inside of work or outside of work?
Either way.
Uh, I would say inside of work is AI. Yeah, the ways that it can be applied, the way number one, there's a lot of kind of mindless tasks that you have to do in medicine that waste energy that AI can do for you, which is incredible. So, for example, a typical example would be the AI scribe. If you have a clinic and you have an AI scribe, clinic is 1,000 times more enjoyable because you can just sit with the patient, look at them in the eyes, listen to what they're saying, and not be worried about documentation because AI does it, better than I would if I was paying complete attention. And then the other part that I find this fascinating is the ability to analyze data, to code. You become a more skilled person. A lot of these things like coding, if everyone were to do it, if you would spend the time to code, and it takes a significant amount of time, you could save an infinite amount of time in the future. But you just don't have the space right now to stop what you're doing and go on a sabbatical so you can learn the code, right? So AI is a way to do that, and obviously there's many ways in which you can vet the code, but I find that the possibilities are endless. Yeah, I know that there's some ethics related to that, but I would say if I were to go back in time and do internal medicine residency with AI, oh, that would have been amazing. Yeah,
Well, maybe next life, you never know. But again, it's good that you're keeping up with the times. Many people have either a lot of fear about AI or a lot of mistrust. And as you say, there are things to work out, and there's some inaccuracies, obviously. But you're right that this can provide many opportunities that were not there before.
yeah.
So, so Juan, if you had to give some advice to people who want to follow your footsteps and do clinical practice, complex cases, CTO, maybe some of the other areas that you're touching, like critical care cardiology, what would your advice be?
Um, like sometimes uh, particularly when I started as staff, residents or medical students were asking for advice as to what the path is to get to whatever it is that defines the place and space and time where you are. And I find myself not necessarily being the best person to provide advice because I ultimately, through many situations in training, I kind of followed my own life path. Let's say, like, there's no clear algorithm for success. I would say, if I were to provide advice to trainees, to look for a good mentor, for sure, but also beware because a mentor is not supposed to tell you how to get to where you want to go. They're supposed to guide you to find your own path. So the path that works for them may not be the path that works for you. And I don't mean that a mentor can get you, like, a good mentor can probably get you the job that you want, but maybe not get you the fulfillment or the sense of belonging that you want because their desires, their needs, their priorities may not align with yours. So I would say, stay open minded, ensure you understand yourself and what you want, because ultimately, the goal is more than just an academic job or a position in a hospital. Like, there's more to fulfillment than that. Yeah.
Wonderful. Well, Juan, again, congratulations. You've done phenomenal work on multiple different areas. Super excited to keep on working with you in the future, and thanks for taking the time today.
Thank you, Manos.
Unfortunately, a few minutes literally after we concluded recording the podcast, the unfortunate news of the death of Dimmitri Karbaliotis joined both of us, and like many others, we were very devastated. So we would like to dedicate a few more minutes of discussion towards the legacy and the footprint that Dimitri has left on the lives of many, including Juan, who you were one of his students, and he was your mentor. So I know that he had a big impact in your life, but what would you say, and what are the feelings that come to the point this mind?
Well, I again share the sentiment that it's very tragic news to find out that Dimitri has passed away. And we found out literally after we concluded the podcast episode. Dimitri, if somebody would embody a sensei in my training, that would be Dimitri for multiple reasons. And I know that he's considered a mentor and kind of a master of his craft to many others in my same kind of generation. And it just felt really uh, uh, really difficult to not have an opportunity to speak about how much of an impact Dimitri had on any or many practicing interventional cardiologists at present. I think he truly did embody the sensei. I think Dimitri was trying to create a school of chip CTO, and he succeeded in that. And he always was very vested in seeing how his trainees were doing and he took a lot of pride in that. And we looked up to Dimitri for or multiple ways. I think during training we looked at Dimitri as a source of knowledge and technical skills. But later points, whenever we met after CTO Plus, we kind of looked at Dimitri for guidance in life and understanding how to find balance um, in a life as operators. Because being an operator is not the one thing that defines us. Like there's multiple other things that we look forth on our time on Earth.
Yeah, no, absolutely. And Dimitri, has trained many people, Sanjog, Raja. I mean, many people, including many people from Canada. There was a special connection, I think, with Canadians and coming to train with Dimitri. Dimitri, could he be a little tough during his training? Would you see this more as a tough love, or how would you approach this? I know it was not always easy, but he really cared, but he was also very demanding.
Yeah, Dimitri expected excellence. And even if we're talking about Sensei and the role of a mentor, like there's kind of different archetypes of what a sensei should be. I think I personally grew up watching Karate Kid and the benevolent Miyagi who has patience and over the course of an extended period of time teaches somebody not just karate but balance, wisdom, and moral code. And then there's the more intense sensei, like let's say Pai Mei in Kill Bill 2, who is the gatekeeper of a great amount of skill. And I guess in the over the when it comes to chip CTO PCI, a year is not a long time. So I think the translation of technical skills um, can be intense, and there's high expectations. But I think I could swear that I saw Dimitri evolve over the period of time that I knew him. From the first time that I met him as an instructor in Chip CTO PCI, where he was basically showing us what to do, and we needed to be disciplined. We needed to listen. It was a lopsided learning experience where the knowledge was coming down from one side um, to the latter part of the relationship with Dimitri. The last conversation I had with Dimitri, as I mentioned to you, my dad had passed away under kind of tragic circumstances. He had been healthy beforehand, and it left me questioning everything and not having a father figure to ask like what now. The first person that I thought of was just contacting Dimitri and saying, what do you think this intense uh quest to be a chip CTO operator, like where does that fit within one's life? That was the last discussion that we had, and Dimitri actually advised me to slow down, to take it slow, to leave more time between cases and explore other facets of life. So Dimitri went maybe from the between the spectrum of Pai Mei to Miyagi. He was transforming into a Miyagi, um, but still very much himself devoted to PCI, excited about a new journey in Atlanta, said that we could do cases. So it's just very tragic to think that he's no longer here, and I feel for his family. Um, yeah, his wife in Alkis.
Yeah, no, major losses on multiple ways. So Juan, I know we talked about this before as well. What should Dimitri's legacy be? People thinking of him in 5, 10 years going forward. What do you think his legacy is going to be?
Um, y- like I think obviously Dimitri has already made an impact in chip CTO PCI. Um, he has inspired many just to pursue kind of a deep understanding not only of how to practice chip CTO PCI in the present, but also ultimately how to transcend and innovate the skill or the art of performing chip CTO PCI. Um, I think his legacy is going to be his family and Alkis. And I really did enjoy when Dimitri, he never, for some reason, he never did it when I was there. But when there were guests, for example, sometimes conversations would spark that did not relate to PCI, like opera or philosophy. I have I hope that his legacy incorporates some of that. I did find Dimitri to be a very sophisticated person. Sometimes in the rush of case in, case out, you didn't have a chance to become attuned to that. But in the instances where he got to speak about his interests outside of I think those were the times that I got to know, the real Dimitri more. To be honest, Manos, obviously he's already left a legacy in chip CTO PCI. I would need more time to think about like what the legacy of a human who is a master in one task should be overall. Because for many people who knew Dimitri, family, he was more than just a masterful chip CTO operator. And that legacy counts too. Um, yep.
Wonderful. Well, thank you again. Thanks, Juan. I know these are difficult conversations. Thanks again for sharing with everyone. And again, our best wishes and thoughts go with his family.
Yeah. Thank you, Manos.
Thank you for listening to the Sensei podcast.